just go. So now I want to talk about the Medicare program. I lost my cursor. So first of all, we're just going to have a quick poll. Have you ever tried to navigate the Medicare program in any way? And so this is not as a researcher, this is as someone trying to understand the program. And while we're waiting for this, we've got a couple of questions. Let's take the survey down. I think I see the questions from Patrick and Logan. And we will address each of your questions in time. Patrick, yours, you should have a pretty good idea of it by the end of this segment. And Logan, I will get to your answer by the end of the day, if that makes sense. It's sort of a complicated one, so let's get everybody caught up, if that makes sense. So survey results. So most of you haven't actually tried to, about 70% of you have said, nope, I've never tried to navigate the program. And but equal numbers have said, I've tried to help somebody navigate through it. And 14% have said you've talked briefly with a beneficiary. So my advice would be, talk to a beneficiary, talk to your grandparents, your parents, your aunts, your next door neighbors. I will tell you personally that I have learned more and understood more about the Medicare program and what I see helping my parents, my husband's parents, aunts and uncles through it, and having to have conversations with people, trying to understand things like, well, why can't I get this paid for? How do I do this? Or how do I talk to a doctor? Or what exactly am I getting? It's an amazing program in terms of how complex it is. And as much as we can look at it from the outside, I certainly have gained considerable insight from having to look at it from within and try to figure out, well, this is, and I've had these conversations, for example, there are circumstances under which eyeglasses are a covered benefit after cataract surgery, but the process of actually trying to get eyeglasses is almost impossible. And so understanding that disconnect sometimes between what is a covered benefit or what isn't, or what are the circumstances, will help you understand and ask insightful questions of the data. So the Medicare program began in 1965 with Title 18 of the Social Security Act. The Medicare program started July 1, 1966. I will point something out. This is the federal fiscal year is actually in October 1. This is one of those odd pieces. Yeah, I don't know if the federal fiscal year moved, but for the most part, major changes to the Medicare program policy-wise will happen October 1. But again, the program started in 1966. It has been repeatedly modified since 1966. And what's interesting is that throughout this entire history, there have been two competing concerns, and the policies have been used to balance them. So first, the concern was, and continues to be, that expenses outpace inflation and expectations. So in other words, the program is spending too much. It's going to go bankrupt. We need to control spending. And then there's an equal and opposite concern, which is the program doesn't cover the care that the beneficiaries are needed. So you'll see that push me, pull you going on throughout the program, where there are, how do we pay less to get more? How do we make sure the beneficiaries get what they need? How do we manage costs? And so while these began in the 60s, these are still policy drivers today. So as you think about questions you're going to ask, or you think about policy decisions, please keep this in mind and ask yourself, how do I understand how these two things fit together and how these will actually translate to somebody on the front lines who has Medicare trying to get care. So the original payment structure for the Medicare program is what's called fee-for-service, which is a crazy name. It ought to be service for fees. So the title is wrong. And what that basically says is providers are paid for services provided. You see somebody, you submit a bill, you get paid. You don't see anybody, you don't submit a bill, you don't get paid. You get paid for what you do. And starting in the 80s, payments are based on standard fee schedules that take into account the amount of work performed and a geographic adjustment. So the small geographic adjustment takes into account that it can be more expensive in some markets than in others. And it also takes into account a fee schedule. And for those of you who've heard of things like RVUs or relative value units, this is a way to try to standardize how much work something is to make the payments for certain procedures more predictable. There are two types of beneficiaries in the Medicare program. There are the elderly. It's occasionally people will call them older, but they're technically elderly. At present, it's about 86% of Medicare beneficiaries. They're age 65 years and older. And approximately 96% of Americans over age 65 are Medicare beneficiaries. So although we worry about who's eligible and who's not, the eligibility is broad. And for those of you who are epidemiologists or thinking this way, this is why this is as close to a population base as you can get. We also have a second program for disabled people. About 14% of Medicare beneficiaries qualify under disability benefits. The disability benefits are based on how the Social Security Administration defines disability, and Medicare benefits start 24 months after disability benefits start. So if you think about it, what this means is we are looking at a low mortality disabled group, because if somebody was in a high mortality condition, they wouldn't survive the 24 months. So when we think about the disabled, and we'll talk about this again, we just have to remember this is not a colloquial definition. This is in fact a technical government definition. These are people that the Social Security Administration has deemed deserving of disability benefits. So there are plenty of people with disabilities who will not be flagged as disabled. So one of the ways that this can cause confusion is saying, well, these numbers don't make sense. But again, it's a process as well as a status. Who are the 4% of elderly Americans who are not covered? They are a range of things. So for example, some people will still be working, they won't claim Medicare benefits, and then perhaps they don't live long enough to retire. It also could be somebody who's in the United States but is not a citizen and does not have a status that would allow for the Medicare program to cover them, although that's pretty broad. So it's usually a mix of people. And then there's also some people who don't ever ask for benefits. They didn't have a work history. They always were in the military. They're getting their benefits, for example, through the military or through something else. So it's sort of a smattering of things like that. There also are two more groups that are relatively that are newer and not as common. There's end-stage renal disease, and there's amyotrophic lateral sclerosis, ALS, or Lou Gehrig's disease. ALS is a relatively new benefit, but for both end-stage renal disease and ALS, coverage begins at the time of diagnosis. So these are new, and these are people who have the federal government has decided need federal healthcare benefits. So I sort of gave this away, but we'll see if anyone was listening. Question: are most people with disabilities found in the Medicare program? Clarifying, most people under 65. Okay, how are we doing on our poll? Is it most people answered? Okay, and so in fact, you are correct. Most people with disabilities are not found in the Medicare program under age 65. And again, that is because the definition for disability benefits has to do with Social Security Administration determining that somebody is not able to work. So it's not just having a disability, but having a disability that interferes with the ability to work. So the Medicare programs, we've talked about the program, and so this is part of the reason why there have been so many concerns. There have been persistent concerns about program growth. So the blue line that you can see is the growth of the aged population, and you can see from 1966 through present, it has been a continuous growth model. The disabled population is actually sort of, I always argue, is a less sort of organic curve. And you can see, for example, around 2012, where the disabled population peaked and then declined and then flattened. Those are based on policies around who is eligible for disability. And then the black line adds the blue and the green together so that what we can see is the total Medicare population. And you can see that growth over the history of the program. So the history of the program has been a program of growth in the United States elderly population, which is absolutely consistent with demographically what's been going on in the United States. Healthcare spending is interesting because, as I've said, a lot of the program policies are based on attempting to control program growth. And so when I ran this, I was sort of stunned because I'd always thought of the Medicare program as growing sort of too quickly. But in fact, you can see total Medicare expenditures relative to total national healthcare expenditures. You can see the two curves splitting quite dramatically. And that is, in fact, the interesting point. So although we're very worried about Medicare expenditures have been far more controlled than healthcare expenditures overall. So when we look at our Medicare enrollees, this is from 2019, it's relatively the same. What we see is about half of the enrollees are between the ages of 65 and 74. About 14%, as we said, are under the age of 65. 26%, so a quarter, are between the ages of 75 and 84. And note that 11% of the beneficiaries are age 85 and older. So although we talk about the oldest old, that is a growing group population and a particularly interesting population in terms of healthy aging and what can be done. So as our population is continuing to drift upward, what can we do to make sure that these people are as healthy as possible? When we look at the enrolled beneficiaries by gender, what we see is overall there's an excess of women. That's the green bar. And that makes sense because, in fact, with the elderly, there are more women than men, a higher percentage. And that has to do with life expectancy, among other things. So women predominate men over age 65. And it's interesting, and I've been watching this, and sometime when I teach this, I'll create the slide. But the disabled population is almost equal male and female. When I first started teaching this course in the 90s, the elderly and disabled were exact opposites. There was about a 10% excess of women in the elderly, and there's about a 10% excess of men in the disabled. And that this is certainly a demographic or a cohort shift with more and more women in this age group entering the workforce and therefore being able to justify needing benefits for not being able to work. So it's a very interesting pattern to see. And I expect that at some point it will reach equipoise. It just about is now, but it's certainly one that has been changing over, well, I don't even want to say how long I've been with ResDAC's. That makes me sound old, but you get the point. So now we're going to move on and talk about the Medicare program itself. And again, this has to do with the idea that if you don't understand the Medicare program, if you need to, then you're going to be able to understand what data you can, what sorts of questions can be asked, and what sorts of questions, when you call to ResDAC, we're going to be able to say, well, It doesn't exactly work that way. So this will help you understand some of those considerations. So when Medicare began, it was created in 2 parts. There was Part A, which was an entitlement. That means everybody got it who was eligible, and it largely covered hospital care. And the idea at the time in the 60s was the thing that was keeping people away from healthcare was their ability to pay to be in the hospital. There was also Part B, which was an optional insurance, and it covered physician services. So this was how it was created in the beginning. An entitlement for institutional care and an optional insurance to cover physician and non-institutional. So in other words, non-inpatient care. So the original structure, just to think about it, is there's Part A, which is that blue bar, and there's Part B, which is the green box, and original Medicare. And so people could have one or they could have both. And that is what original Medicare is. It's paid under what is called fee-for-service. What happened when Part C began in 1982 as part of the Tax Equity and Fiscal Responsibility Act is we added managed care. And it was called Part C. And the challenge, I think, with this labeling is that Part A and Part B were sort of additive. And so the idea that Part C wasn't additive, but was in fact was an alternative, has caused a tremendous amount of confusion. So Part C is a contrast to original Medicare. So people in original Medicare, fee-for-service, Part A is an entitlement, Part B is optional. They can have either Part A or Part A plus B. Part C is an alternative to original Medicare that is also comprised of Part A and Part B. So again, you can see this confusion of how it puts together. Real quick, Patrick wants to know if somebody has no history of paying into Medicare during their work years, they could not get coverage even if they're a legal citizen. So in order to be eligible for Social Security, and according to and then from there, you have to work 40 quarters. So if you work one day even, you will get eligibility for that quarter of work. So for example, it could be working 40 quarters would be 10 years of full-time work. I know, for example, I started getting my quarters as a high school student because you work a job, somebody pays a W-2, they take up Medicare taxes. There also are ways to buy it down. Spouses who have worked, you can get Medicare benefits and Social Security on somebody else's work history, on a spouse or on a child. So it's a more complex story of how you get it. But again, I think what it really points to is this idea that there's an interest by the program in getting as many people who are eligible covered by the program as possible. So anyway, so now we've got original Medicare. In the 80s, we added Part C. So you can either now get one of 2 options, original Medicare or Part C. In the 2000s, we added Part D, which was the pharmacy benefit, and that's seen by the yellow column. Part C is almost always bundled with Part A and B for managed care enrollees, and it's seen as an option for people with original Medicare. So you can buy it, it's an original initial premium. The Part D benefits were added by a group, by a sort of a large consortium of interested people, including, for example, the National Cancer Institute, the National Institutes of Health, who were arguing we're paying for all these scientific dollars to develop new chemotherapies, oral medications, and yet nobody can get them covered. So this was Part D to make sure that people had drug coverage and had control of it. And again, there's a course on Part D that is offered, and there are resources on our website. So Medicare Part A benefits include hospital care, a limited skilled nursing facility care benefit, home health care for people who need skilled nursing and rehabilitation care, and for people who are confined to home, and hospice care. So that is what the Part A benefits are. Part A eligibility, as I said, if you or your spouse worked 40 or more quarters in their lifetime and paid Medicare tax while working. If you did not work 40 quarters, you can pay a monthly premium in addition, so you can buy into this entitlement. And as I said earlier, 96% of the people who are in the 65 and older bracket are enrolled in Part A. So between the two choices, we get very high levels of participation. Medicare eligibility, as I said earlier, if you receive Social Security disability insurance benefits for 24 months, you can get it. And people with end-stage renal disease will get it at time of diagnosis. And I saw a note in the chat about how long the benefits last after kidney transplant, and people with ALS at time of diagnosis. So here's one of the questions that we all struggle with. What happens to a person who's disabled, who receives disability benefits when they turn 65? Okay, so we've got about 102 have answered. Let's close the poll and see what the consensus is. So I'm impressed. So 75% of you got it correct, that when you turn 65, you are now begin coverage by age. Some of you said, well, they remain covered due to their disability. And the answer is it's sort of odd, but because what it is it's the disability benefit is an age limited. From a beneficiary's perspective, it's actually, you can't see the difference. They still have coverage. They still get their same Medicare card. They still have their same co-pays. But in the system and what we see, they will no longer be disabled. They will begin coverage as somebody who's elderly. So we will talk later on this afternoon about how can you look at people who were originally covered who are originally disabled, and look at what happens to them as they get older. How do you find them and how do you do that? So we'll talk about that later today. So the money. So there were a few economists in this group, but it's important to understand it even if you're not an economist, because it will affect what people do and how they make decisions. So with Part A, there's a deductible that's due to for each, and this is such a Medicare term, spell of illness, and it's equal to 1 day of hospitalization. So in 2020, it was about $1,400. So in other words, this is an explicit recognition that sometimes one particular event will result in multiple healthcare usages, and so the deductible covers the entire event that happens. So for example, if somebody breaks their hip and is hospitalized and then goes to rehab and then has trouble with their implant and goes back to the hospital or whatever, that is going to be seen as all one spell of illness, one event. And so they will not get a new deductible for every single part of that, as long as it is one sort of continuous event. If you're interested in spells of illness, we can help you find documentation. I will tell you, it is amazingly complex and to my mind, a little frustrating to try to sort it out. So there are rules. This is a federal program. We can figure it out, but they are not simple rules. There also are co-insurances that people need to pay for hospital and skilled nursing facility benefits. So for people who are hospitalized for more than 60 days, they will pay a quarter deductible for each day of hospitalization between 61 and 90, and half deductible between 91 and 150, and all costs beyond 150 days. So it's a very generous benefit. And then for skilled nursing facility care, there's a co-insurance for days 21 to 100 of skilled nursing facility care, which is $176 per day, which is an amazingly affordable copay if you've ever looked at nursing home care or even just senior living. And there's no cost sharing for home health or hospice. And again, so some of this with CMS is very good at using the deductibles to try to incent certain types of healthcare decision making. So when we think about the files you use, if you want to look at original Medicare and you want to look at Part A benefits, you would ask for the home health agency file, the hospice file, the inpatient file, and the skilled nursing facility file. So those are the types of care that are covered under Part A. And for each type of care, there's actually a different file. So Part B, remember, this is optional, and it covers physician services and services covered by other types of providers, such as health departments. And it covers facility charges for hospital outpatient services and ambulatory care centers. And it covers durable medical equipment. So it's kind of an interesting mix of things. Beneficiaries must pay or have somebody pay on their behalf to be enrolled in Part B. Usually the premium payment is deducted from the monthly Social Security check. And that is a benefit, because one of the things, especially as people get older or as they are frail, the last thing you want to do is risk losing Medicare benefits due to failure to pay. If you don't enroll at the time of first eligibility, but enroll later, you will have to pay an added premium. So 10% per year of delay. So the idea here is, and this started with the program, they didn't want people to only get their benefits when they were ill. They wanted it to be more of a true insurance program. So you pay before you know whether or not you're sick. Over time, one of the things that have happened, and I don't have the year when this was, it was in the 2000s, Part B premiums used to be exactly the same. They were standard. And at some point, they began changing them to be indexed on income. So right now, payment range for Part B benefits ranges from $144 a month to $491 a month. That was 2020. So it used to be that everybody paid the same. And now, depending on your income or your wealth, you will have different monthly premiums. There's an annual deductible. In 2020, it was $198, and there's a 20% co-insurance. The exceptions for co-insurances are clinical laboratory tests, certain preventive care, such as influenza, pneumonia vaccine, PSA, so prostate-specific antigen testing, will have no co-insurance or deductible. Interesting, mental health services used to have a higher copay, and in 2014, the copay for mental health became the same as for medical. So if you're looking long-term and you want to look at how that change in copay changed use or presence of diagnoses, 2014 would be your pivot point. And I personally think that would be quite interesting to understand how hospitals responded or didn't respond to that. Just so you can see, this is common knowledge. This is from the New York Times crossword puzzle. And one down, the question was, what is the Medicare section that covers flu shots? The answer is Part B. So again, Part A and Part B is again common knowledge. We got a question, are the Part B premiums adjusted in a similar fashion to the fee schedule? And the answer is no. The fee schedule is based on work with a geographic adjustment. There is no, at least as far as I understand, there's no geographic adjustment to the Medicare premiums. The premiums are the same whether you're in a high cost or low cost state. They're just indexed based on wealth. So if we wanted to look at Part B services for original Medicare, we would ask for what's called the carrier file, which has the physician services and some facility charges. We'll talk about those tomorrow. It will have the durable medical equipment file. It will have the home health agency file. So some home health agency care is Part B, and some home health agency care is Part A. And then it will have the bullets got a little bit off here. I apologize for not catching it. And then it will have what's called the outpatient, and that's hospital outpatient care. We also have the Part D data. So this is the pharmacy data. And pharmacy is interesting because if you look at the number of files that there are basically as many files for the pharmacy as there are for Part A and Part B. So there's what's called an event file or drug file. There's a characteristics file, formularies, so you can see whether or not what the plan covers. There are pharmacy characteristics, election types, and summary characteristics. So again, there's a lot of detail on Part D. It's covered in another course, but we just want to point that out here, that those data are available, and with minimal exceptions, all of the pharmacy data will be in the Part D data. So Medicare Part C, this is the tricky part, right? Because it's not parallel to Part A and Part B, it's an alternative to original Medicare. So as we said, Medicare Managed Care began in 1985 as part of the Tax Equity and Fiscal Responsibility Act of 1982. And it's been renamed about 4,000 times. It started off as M+C, Medicare Plus Choice, MA. It's been renamed. So if you look at the old literature, you will see it called really an interesting number of things. Some are quite creative, but in fact, the program is essentially unchanged from what it was in the 80s. In order to enroll in managed care, you must have both Part A and Part B, and you must continue to pay the Part B premium or have it paid for you. Medicare Advantage, the plan assumes the risk. So these are capitated plans. So the plan is paid by CMS on a capitated basis, and then the plan assumes the risk for all care that is needed. The basis for the payments has changed multiple times since 1985, but the structure really hasn't. So right now, capitation is based on what are called the hierarchical condition codes, or HCCs. And you can look these up. And what this does is this says, well, we're not going to pay the managed care plan the same for everybody because we don't want to create a disincentive for taking on risk. And we know some patients are inherently riskier than others. Originally, the payment was based on 95% of the average annual per capita cost, which was calculated by county. So originally what would happen is we would say, okay, I'm in Alachua County, Florida, and the average annual per capita cost for Medicare in Alachua County is $10,000. I'm making the numbers, $10,000. We will pay the plan 95% of that to be responsible for people. So that's how it was originally. Now it's based on capitation person by person. So we would say we've calculated an HCC for Mildred, and based on that, this is how much Mildred's plan will get. Currently, it's estimated that the plans are paid between 10 and 14% more than the cost of a similar fee-for-service beneficiary. Kaiser Fund, in one of their most recent reports, said 11.2%. The other piece to know is the encounter data, which I mentioned when we talked about courses. The encounter data reported to CMS, and they were released for the first time in 2018. So we are now in a which was when calendar year 2015 was reported. So what's nice is we now have multiple years of encounter data. So now it's actually possible to directly compare the use and the patterns of care for people who are on Medicare Advantage and Medicare Fee-for-Service. Medicare Advantage plan has a very interesting, and I would argue, non-organic growth curve. So what happens is, in my experience, when you get curves like this, where the enrollment was at one point is about a 17%, it declined, it went up. Not all rises are equally steep, some are different. What those signal is policy changes. So where you see those inflection points, for example, there's one around 2016. That is a place where there was a policy change that was done to incent or disincent use of managed care. So if you're interested in managed care and you're interested in who goes into managed care or what their care is, looking at a graph like this and looking at where the curve bends and twists a little bit, might give you some ideas of places to dig into the legislation to say, well, what was the change that happened here? And how did it work? And what sorts of things might I use to think about it? There's a question about how Part B premiums are they based on income or previous current income? I don't know. I don't know how exactly they calculate it, whether it's based on taxes or what. I actually could probably figure it out, and we can look it up. I don't know. Maybe somebody else from ResDAC who's on the course stuff. I think Nate was on for a while. Do you know how the Part B premiums are indexed?
I knew at one point. I don't want to say for
I
sure.
did too, right? How about this? If we figure it out, we'll put a note in the chat. But I think that's a good question. And with that,
there are a couple of questions about clarifying the interaction between Part A and B and Part C, and whether Part C is synonymous with managed care.
So Part C is synonymous with managed care. So this is part of what happens is that, and this is where there's the confusion, is because it's been renamed so many times that people aren't sure what it is. So Part C means managed care. Managed care still is subject to the Part A and Part B benefits, as is original Medicare. So that is, again, why these things can be so challenging to get your head around. And then Part D is pharmacy, and again, pharmacy is a benefit and holds for both original Medicare and Part C. So what were the key motivations for adding Part C? So the Tax Equity and Fiscal Responsibility Act is a fascinating act. This is just for those of you who are sort of policy-ish. And it did three things. It started Medicare managed care, which was believed, and the theory at the time was that it was a cost savings. It started the DRGs, the diagnosis-related groupings, which is a way of paying prospective payment for hospitals. And hospice started as part of the same act. And hospice is seen, depending on your perspective, is either a benefit to patients because it allows them to get out of hospitals and get care in a home in a setting they might like, or it could be seen as a way of transferring the costs of care from institutions to families. So the Tax Equity and Fiscal Responsibility Act really is an act that was about controlling costs while trying to balance and make sure that beneficiaries didn't lose access to care they wanted. So that's how Part C happened. And then there's a question, is it correct to say Part C plans automatically include Part D? I think the answer is pretty much. I have not seen any Part C plan that doesn't include Part D. It wouldn't have to, but I don't know of any that actually doesn't. So I think it could just be how the plans are put. I think plans often use it as a marketing ploy as well. You know, not only do you get your Medicare Part A and Part B, but you get Part D as well. So I don't think they have to, but I think they all do all Part C plans include Part D. I can't think of I haven't found an exception when I've tried to look for them. So Medicare Advantage. 40% of Medicare enrollees were enrolled in Medicare Advantage plans in 2020. The percentage of Medicare Advantage enrollees varies dramatically. It used to be that if you looked at the commercial managed care map from the 70s, it almost exactly matched the managed care map in the 90s for Medicare. It's now, as healthcare has changed, that's less correct. But there still is more managed care in urban areas than in rural, though rural is definitely catching up. And there are certainly state-to-state differences that I think have to do as much with historical markets. So Alaska is very low managed care at about 2%, and Florida, Minnesota, California, Hawaii are all high managed care states. So there definitely is geographic variation, and I will show you that. The average monthly premium in 2019 for a Medicare Advantage plan, which is in addition to the Part B premium, is about $26. So this is, you can see the map and you can see the geographic variation, and you can see it's an interesting map, because I look at it, in some cases I can say, well, that makes sense, and in other cases I have no idea. For example, if you look at the South, why Mississippi is such an outlier, surrounded by Louisiana, Alabama, Georgia. So I think the bottom line is, if you're doing a national study and you're using Medicare data, you are going to want to look at the map to really understand the impact of managed care on what you're doing. So again, if we look at managed care data, which is Part C, you'll see that for the encounter data, we have home health, inpatient, and skilled nursing facility. So the same file names. For Part B, we have carrier, durable medical equipment, home health agency, and outpatient. But notice hospice, and hospice is up under original Medicare, and hospice is a carve-out. And what that means is when they wrote the Tax Equity and Fiscal Responsibility Act in 1982, there was a belief that the financial savings of hospice would be so great that they wanted to keep those savings for original Medicare and not allow the Part C plans to get that. I don't think, and my own research, I don't think has ever pointed to that exactly being what happened, but that is the theory, and that is why if you want to study hospice in encounter data, you need to use hospice from the original Medicare, so you can use the same file for both groups. So to understand the difference between fee-for-service and managed care, fee-for-service, the providers are paid by CMS directly for the services provided. The payments are based on standard fee schedules that take the amount of work performed and a geographic adjustment into account. In managed care, the providers are paid by the plans to provide care. The payments to providers are negotiated by the plans, and CMS pays the plans a monthly payment. The plans accept the risk for the care that exceeds the payment. So one of the challenges and one of the differences is we actually can know much more about the payment rules, what is allowed, what requires things for fee-for-service than we do for managed care. So just that's the big thing, is just to remember sort of the role of the providers and the negotiation between the providers and the plans is different between original Medicare and managed care. Part D, as I've said, is the prescription drug program. It was implemented in 2006 as part of the Medicare Modernization Act. And it's a model where beneficiaries can voluntarily purchase drug coverage offered by private plans, but the plans have oversight by CMS. Part D plans have flexibility in the design, the benefit package, including deductibles, copays, formularies, and the premiums will vary by plan. But again, all subject to approval and oversight by CMS. The plans are state or regional based. There are standalone prescription drug plans, which may be purchased along with traditional or original Medicare. And there are managed care prescription drug plans that are included in Part C. So there are different types of plans. And when you're looking at the Part C data, you're going to want to take that into account. Part D enrollment is for calendar year, and beneficiaries may choose from multiple plans during the annual open enrollment period. Enrollment in Part D is optional, but there's a penalty for those without what they call creditable coverage, which is equivalent coverage who enroll after age 65. So in other words, if somebody doesn't have coverage and then later wants it, they will pay a penalty. The reason for creditable coverage is for many people, like part of retirement benefits from their employer, from unions, will include pharmacy coverage. That was sort of developed over time with the lack of pharmacy. So with those, the idea is that people shouldn't have to pay for prescription drug benefits when they already have other coverage. And for those who cannot afford to pay for this extra, for the premiums, there's extra help, which is called low income subsidy. or LIS. So when you see that, so what that is that's help, which is separate from this, from the premium and copay support for the other parts of Medicare. Medicare Part D enrollment is actually pretty complete and steady. It began in 2006 at about 55% and very rapidly changed and is now holding steady at about 75%. The percentage of people who don't have credible coverage and aren't in Part D is vanishingly small. So Part D, we see 42% are Medicare Advantage Part D plan, 55% are a fee-for-service prescription drug plan, and then there's a smattering of employer direct plans, regional PPOs, and so on. So it's pretty much what you'd expect given what you now know about the fee-for-service and managed care enrollment. So this is the whole smattering of Part A, Part B, Part D, and original Medicare and Part C. And the question was, so Abby looked it up. Thank you, Abby. I appreciate it. And Part B premiums are calculated on income reported on tax returns from 2 years prior. And the question was, any idea for why 2 years? And no, I don't know. I'm sure there was a logic of trying to balance out, you know, perhaps as somebody transitioned from working to being retired and their income changed, helping them sort of ease out of that. That would be my guess, but I really don't know. So low income people, there are a variety of ways that low income people are helped to get their health care. There's state buy-in, which is where the state will pay the Part B premiums and the copays and deductibles for Part A and Part B. There's dual Medicare and Medicaid, which is a combination of full Medicare and Medicaid benefits, so not just premiums and copays. And then, as I said, there's support specific to Part D. And if you give me just 1 second, I just need to, there's a lot of hallway noise, so I'm going to just ask people to, given that I'm the dean, I guess I could tell them that. Sorry about that. So all states participate in programs to provide assistance for low-income Medicare enrollees to help them meet the premiums, copays, and deductibles. So the idea of the program is set up so that nobody should be prohibited from joining Medicare because of cost. So when we look at dual Medicare enrollment over time, so dual is full Medicare and Medicaid. Partial Medicaid is help with premiums, and Medicare only is no help. You can see the patterns are amazingly steady, which I think is pretty fascinating. So about 81% of people are Medicare only, about 17% are full Medicaid, and about 5% or so consistently are partial Medicaid. That is to say, they get help with premiums, but they don't get the full benefits. So when we look at dual eligibles as a percentage of Medicare beneficiaries, again, we can see some regional differences. Now, some of these regional differences really indicate state policy. So, for example, if you look at the difference between New Hampshire and Vermont up in New England, the best explanation that I see for why those two states, which are 90 miles across each of them, have different percentages of duals has to do with state policy rather than the presence of poverty. But you can again see, so when you're looking at duals and you're looking at the role of poverty and helping elders, you could imagine some natural experiments floating around here. So one of the things when we talk about opportunities that I think we don't do enough of is really look for the natural experiments associated with state policy. So when I show you these maps, in part what I'm actually suggesting is we all probably could look and say, I wonder what's going on. And I wonder if we see a difference between how things are managed in Pennsylvania and New York, when they clearly have either different levels of poverty or different levels of support for people who have financial problems. So don't forget to ask these questions. They can be incredibly helpful and incredibly important as we try to understand the program. The question is, just going through the chat, there was a question about donut hole coverage gap and how does that show up in Part D, and that will show up claim by claim, the amount of copay, deductible, and so on. So it will be, so you will see that. And we'll talk about how to link, how to put the data together from these different sorts. We'll be going through that starting after lunch, and then Sammy will tomorrow afternoon talk about how do you actually create an analytic file and what are the steps and things you might want to consider. Why are Medicare Advantage plans moving from Medicare to Medicare Advantage? Is it a government initiated process? And I think the answer personally is advertising. If you start paying it, my family hates it when there are Medicare Advantage commercials on because I start yelling at the TV. I think that some of the advertising is completely misleading and confusing. And so that is my theory, is people are moving to Medicare Advantage because they really don't understand. But that's just me. And how often does someone's dual eligibility status need to be updated? I think that's actually a state policy question. I think technically it's often annually, but it's really up to the state. So again, the dual part of it, the Medicaid piece of it, if you remember, is a state federal partnership that is managed by the states. So the states implement that. But again, I think there are general rules. And if you remember coming off of COVID, there's certainly reaccreditation processes. And does Medicaid only subsidize original Medicare or Part C also? Medicaid will subsidize either one. They cover the premiums and the copays and the deductible. And honestly, Medicaid, many states would prefer that Medicare enrollees were in managed care because it's easier, because a lot of Medicaid enrollees are in managed care. So it's sort of their default way to handle things. But again, that's a state by state decision. So Part D. So one of the things to point out is that Part D, again, we have help. So there's premiums to get the Part D coverage. About 29% of people who are in Part D will get extra help with their pharmacy payments. So that's low income subsidy. So 29% receive low income subsidy, 71% don't. And in some cases, the decision about whether or not to get Part D or not shows that there is a wealth component to this. So we combined the Medicare Current Beneficiary Survey, which is a small survey, with the Medicare enrollment data. And what we found was that for people who reported earning annual income of less than $15,000, 90% of them had Part D. But notice by the time you got up to people whose incomes were $40,000 or higher, only about 70% of them had Part D coverage, and the other 31 had creditable coverage or other sources of payment for their Part D. So this is interesting. I think it tells us a lot about wages. It tells us a lot about retirement benefits that probably is important to understand. But it also might suggest that as we're trying to understand the Part D program, that we keep in mind who we're not seeing, who is not being included in our analysis because they do not need the benefits. So this is, again, one of these themes you'll be hearing from us throughout, which is don't just focus on what you see, but don't forget to look and ask about what you don't see to make sure that in fact you've got a comprehensive view of what's going on. So, and we're well ahead of schedule, which is good because that will give us time to answer some questions and to give everybody a break. But as a reminder, Medicare is an insurance program. So our ResDAC's first project officer in the 90s used to say to me, Medicare is a tiny little insurance program that has decided to release its information to researchers. And it was sort of tongue in cheek because it's by no means tiny, but it's a reminder. And we really have to keep this front of mind. This is an insurance program, and a lot of the data that is collected and a lot of the way things are done and what is considered important is really done from an insurance perspective. These data are incredibly useful for researchers, but they were not collected for research. They are correct. They are collected for insurance purposes. The Medicare program regulations are congressionally controlled. So sometimes we get really, really frustrated. Like, it feels like it would take an act of Congress to change things. Well, the answer is it actually would take an act of Congress to change things. So change can be slow. There's a lot of space in what's called rulemaking, because again, the Congress doesn't vote on which CPT codes to include, but gives broad directions that need to be implemented. But it does mean that the scope of the program, what it was designed to cover in the 60s and how it has changed has been controlled by Congress and congressional decisions. And changes to the program have needed to and will continue to need to balance spending to control and unmet need. And so as you look at a program, or as you look at understanding the unintended consequences of a policy change, this is a space that I would encourage you to think about, is how are we balancing unintended and intended consequences? So when you use the data, you need to be aware that what you're able to study and what you're able to see will be determined by programmatic need rather than scientific planning. So there are many times where, what it would be really nice to be able to see something, but in fact, we don't have the information. Nate will be talking about that more later on today. But again, we only can see what we can see. And so you really need to keep that in mind and really get your head around the program and think about it and think about how this history, this philosophy that we've been talking about is going to be translated to claims. And so ultimately, the reason I use these data, excuse me, but also the reason they're hard is that they require creativity. You have to stop, you have to think, you have to kind of like logic puzzles a little bit to balance the strengths and challenges associated with this data source, and trying to say how can I actually get into sort of a quasi-experimental design mode. So with that, I have questions, and I see some in the chat. What are the percentage of Medicare enrollees in original Medicare or Part C? And that was from earlier, and if you remember, it's about 40% Part C, 60% original Medicare. So the question is, what happens to medications that can come through medical or prescription benefits? So the prescription rules are goofy. So first of all, when somebody is an inpatient, medications are rolled up into the hospital payment. So those would not go through Part D typically, though there are some people pushing the limits of that. Medicare, original Medicare's, which then means both Medicare Advantage, covers IV chemotherapeutics or their metabolites that are available in either IV or oral form. So what that means, for example, is 5-FU is the best example of it. It's a really common chemotherapy that is used for treating colon cancer among others. And what happens is they created an oral form of it. And so it's an IV, it's an oral equivalent of an IV drug. And so the oral medication is covered in the Part B data. And so that you would see there. But for example, there is no IV tamoxifen, which is a breast cancer drug. So even though that's also an oral drug, that is a Part D drug. So there definitely are these oddities of understanding. But we've looked and we never found 5-FU in the Part D data. So Part D plans are very good at saying, nope, that's not ours, that's Medicare, that's original Medicare, and transferring it back. So sometimes what you might see in the Part D is you might see denied claims, but then if you look and give the data a little chance to spin, what you'll see is you'll see them come back to original Medicare's. So, and again, the pharmacists are completely fluent with this. But the things that original Medicare, which again means Medicare or Medicare Advantage cover, they cover, and what is left, which is the vast majority, is covered by Part D. So that's sort of the order of payment. Are there other questions?